To the organizers, thank you all for sticking here till the bitter end. So these are my disclosures. And I'm going to heavily focus on the guidelines that I led as part of the ACG. This is the first GI Society-led guidelines on acute and chronic liver failure. Before we go any further, let's talk about what is acute and chronic liver disease or failure, ACLF, and how is it different from decompensated cirrhosis, which we often see, or from acute liver failure, which is the other extreme, where the liver is actually normal beforehand and something catastrophic happens and the liver basically fails. How do we define and prognosticate patients with ACLF? What are the precipitants and potential prevention strategies? I'm going to focus more on the prevention because currently the management of ACLF or acute and chronic liver failure is not necessarily that different from the individual components that we are already doing. What are the individual organ failures that we need to focus on? Should ACLF patients get priority for liver transplant? You know, currently we use MELD and MELD sodium, and now it's going to be MELD 3.0, but should these patients get priority? And I'm going to talk about why and why not, and what are the future directions. So let's start with a case. If you get very bored, you know, you've eaten a lot or whatever, not had enough coffee, just focus on the red stuff. The red stuff is the important stuff in this case. Patient, new onset confusion, increased abdominal girth, has not been seen by people in the past, has been afebrile, is oriented only to place, and has a fluid wave right now. So clearly this patient is confused. He has not sought outpatient care for 3 years after losing his job during the pandemic and has no insurance. He had to undergo an emergency inguinal hernia strangulation surgery around 6 weeks ago. Currently his creatinine is 1.3, bilirubin is 2, albumin is 3.1, INR is 1.4, WBC count is 7,000, and platelet count is low. So you see there's a low platelet count, low albumin in a patient with high INR as well as higher bilirubin and creatinine, which is creeping up there. So there is almost no doubt that this patient has cirrhosis. Now he has been in the ER for 8 hours, finally admitted for a diagnosis of cirrhosis, ascites, and hepatic encephalopathy, started on lactulose, some improvement, but not really that much. 14 hours, finally someone said, oh, this person has ascites, let's do a TAP. Let's do a paracentesis, and that TAP showed spontaneous bacterial peritonitis. But that 14 hours are very costly because what has happened? His serum creatinine has gone from 1.3 to 1.8. And you're like, that's not that big, right? It is huge. 0.3 milligrams over 48 hours increase in serum creatinine is considered acute kidney injury. And that is independently associated with death in patients with cirrhosis. So it's really critical for us to actually follow the trend of creatinine in these patients. You know, WBC count went from 7,000 to 8,600. It is concerning. Urinalysis is bland. There's no other reason for this person to have any other infections. So SBP is what we've diagnosed it, and we started him ceftriaxone and albumin. 48 hours later, patient is still disoriented with new onset shortness of breath. Remember, he's confused all the way through. He did not go to an ICU setting. He went to a regular floor, despite being confused. Creatinine has now jumped up to 3. Sodium is down to 130, bilirubin is 3.5, and INR is 1.8. Everything is worsening slowly but steadily. A repeat TAP that is typically advised in patients who are not responding shows a less than 25% reduction in polymorphs, shows that this person is not actually doing well. Now the antibiotics are expanded to meropenem and vancomycin. IV norepinephrine is initiated, and he's right now in the ICU. He's tachypnic, hypoxic with a new right lower lobe infiltrate. He's obtundic, anuric with a low MAP. Everything is thrown at him, does not work. This patient ultimately passes away without a liver transplant. And it all started with people not realizing that this person needed a TAP. That's it. These are things that happen so quickly. And what this patient developed was acute and chronic liver failure, but a very preventable acute and chronic liver failure because of 2 reasons. There was a lack of diagnosis or lack of actual workup for ascites, and in a patient who is confused, that may be the only indication that this person is infected. Second, the patient had an appointment, had surgery 6 weeks ago. So this person, if he is infected, would be exposed to healthcare associated infections or not a community acquired infections. So the first thing after drawing the cultures would have been a broad spectrum antibiotic and narrow it as things go wrong, because we were essentially not treating him adequately for 48 hours. Ceftriaxone was not working in this person. So why is this important? Because gut liver changes and immune changes are the hallmark of acute and chronic liver failure. Majority of the patients with cirrhosis actually have immune dysfunction. That drives gut microbial changes, intestinal barrier dysfunction. These bacterial translocated bacteria itself, as well as their products, cause end organ injury, not just in the liver, but all throughout the system. And how is it different from acute liver failure? On your left-hand side is acute liver failure. This is fortunately a very rare condition. These patients have no liver disease. Something happens, they have acute hepatitis, viral hepatitis, or they take medications. In the US, it's still most common is acetaminophen, but other drug-induced liver injuries are also common. And the liver basically fails. Why is it important for us to differentiate from a clinical and therapeutic perspective between ACLF and ALF? ALF patients get extra points. They put them right on top of the list for the for transplantation. ACLF patients do not get any such thing. And we are going to talk about in the next few minutes why or why not it's important for us to prioritize these patients. So patients, infections, like in our patient, was the #1 cause of precipitation in patients with chronic liver disease, compensated or decompensated cirrhosis, to cause this massive systemic organ failure. So acute liver failure, normal liver disease, something bad happens, liver fails, extra points for transplant. Acute and chronic liver failure, no. So if you have a patient whom you have no idea what their original liver disease was, you have to actually look whether this patient had underlying cirrhosis or not, because then if you do not manage these patients yourself, when you go on the phone and transfer this patient to a transplant center, you need to give them all the information to see whether this is a status 1 or not. How do you define it? Long story short, very poorly. No one knows how to define acute or chronic liver failure except when it's too late. Look at these definitions. NACSELD, dialysis, NACSELD, we led it. Dialysis, MAP use, vasopressor use, mechanical ventilation, dialysis. You do not need to be a doctor to tell that this person is going to do very badly, right? It's too late. Our biomarkers for ACLF are pretty bad. And if you look at the APASL ACLF consortium, that's more defined towards people who have hepatitis B flares in patients who have chronic liver disease. So if we have to meet somewhere in the middle. So the ACG definition is potentially reversible condition in a patient with chronic liver disease with or without cirrhosis. So you don't need to have cirrhosis to have acute and chronic liver failure. That is associated with the multiple organ failure or mortality within 3 months, unless you fix something. But this is a retrospective thing, because you have to wait for 3 months to see if something happens. Unfortunately, this is kind of the best definition we have of ACLF, which makes it very hard because there's a discordance between prognostic and diagnostic therapy biomarkers. You have ACLF, you have acute decompensation, you have acute liver failure that we just talked about, and patients in critical care without liver disease. There are no biomarkers right now that can differentiate these things. What you do need is an objective biomarker that is reliable and specific, can be easily translatable into clinical practice, and can guide transplant. Moreover, a lot of these definitions rely on things that are either too expensive, not accessible, or not available worldwide. In this study, which was the cleared consortium that we just did, it was published in Lancet, we found that the death was predicted not just by the liver disease, but by where you were born and where you were actually taken care of. These countries that are in the yellow arrows had a poor prognostication, not because their liver disease was worse. It's just that they did not have the resources, or the patients could not afford the resources, and they did not have access to a liver transplant. So this puts things into another perspective, is to us to make definitions that are not just available and applicable in our sphere of influence, but something that can guide treatments worldwide. So we talked about acute and chronic liver failure, how it's almost impossible to diagnose meaningfully for us to provide care for one specific patient. But it is still an important thing, because when you take liver failure plus other organ failures, you need to remember this patient needs to be transferred ASAP, or these things need to be prevented. What are the organ failures? Brain failure or hepatic encephalopathy is mostly hepatic encephalopathy. So just because someone with cirrhosis comes in with confusion, don't necessarily assume that it is hepatic encephalopathy. It could be other things. It could be patients hitting their head in the past. It could be infections causing just this and not just encephalopathy. You want to initiate general care and prevent aspiration. Our patient came in with encephalopathy, was sent to a regular floor, developed aspiration pneumonia, which basically sealed his fate. He was not going to get better with that aspiration pneumonia despite being on many things. This is something that unfortunately is not really in the hands of specialists. So you want to talk to your ER physicians, you want to talk to your ICU people, you want to talk to your hospitalists that this is something that they act on immediately and contact the ICU sooner rather than later, not when the patient is gasping and is febrile. That's too late. You want to figure out when someone is actually confused. That's the time to consult the ICU. You want to treat them and find out what the precipitating factor is. In our patient, the only symptom for an infection was his confusion. And that's it. You had to figure out why this patient was confused. And if all this regular thing, if he has ascites, that's what you need to tap. And the longer you take to tap, the longer you take to appropriately treat this patient, the worse off things are. And you need to make sure that you give treatment. And if the patient is able to orally tolerate, of course, lactulose, otherwise you'll get lactulose aspiration. Enemas are very good in patients who are more advanced. The other thing we want to figure out is delirium, agitation, as well as pain. These are also very problematic in our patients. And in patients with cirrhosis, hyperammonemia, alcohol intoxication and withdrawal, sepsis and medications for sleep and pain can also cause this. So that's why we recommended the use of short-acting dexmedetomidine for sedation and against prophylactic antibiotics in these patients. So if you have any problems remembering what it is, look at the top. Not all high creatinine is AKI, okay? But it's important for us to realize not all high creatinine is hepatorenal syndrome. Before you get this knee-jerk reaction to say, oh, the creatinine has gone up in a patient with cirrhosis, this is HRS. Let's start this person on terlipressin. No, 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 no. Terlipressin has many, many side effects. It can cause it can actually be fatal if you're not used in the proper patient with correct monitoring. Many patients will not have HRS. HRS is a diagnosis of exclusion. If you look at the one in the bottom, you need to have high rate of AKI, not just that 0.3 that we were talking about. It has to be doubling of that. It has to be no improvement over 48 hours, and the patient does not have to have an intrinsic renal disease. That takes at least 48 hours to make that diagnosis, and then you can start the terlipressin. Starting terlipressin before in a patient who has acute tubular necrosis or is simply dehydrated is not going to help that patient, is actually going to harm the patient. So it's important for us to realize that not all high creatinine is hepatorenal syndrome / AKI, but it is important for us to realize even minor, what we think is minor increases in creatinine can be profoundly problematic. So in stage 2 and 3, we suggest IV albumin and vasoconstrictors versus albumin alone. So when you have albumin plus terlipressin, it does much, much better than albumin alone. So if you have access to terlipressin, please use it, but use it in a patient you know has HRS AKI. In a patient who, if you do not have access to terlipressin, norepinephrine also works in the ICU setting, which is what we had tried with this patient. The other important thing, coagulation failure. INR is not the be-all and end-all. INR is a very bad coagulation test. It's a very good liver function test. So you can actually follow the INR and see how badly the liver is doing. But please do not try and correct it unless there is an absolute procedural thing or the patient is actively bleeding from somewhere, because you will lose a prognostic marker that you need. And if the patient is going to be listed, it's a huge part of the MELD score. It can actually reflect the patient's current situation. What we do want, do not use this as a measure of coagulation risk. A high INR or a low INR does not actually dictate whether someone is going to bleed from a procedure or spontaneously bleed or not. What is really important is this method called thromboelastography, in which it's a very pragmatic way. You take the whole blood and you spin a needle along it and see how strong the actual clot is. It takes care of everything, the platelets, the fibrinogen, the coagulation system, and not just one part of it, which is the INR. So INR is not the be-all and end-all for coagulation. It's much more nuanced in our patients. So let's go about precipitating factors. Alcohol-related hepatitis is really common. Unfortunately, with the pandemic, it's gone on. Surgery, please use either Mayo Clinic or the Vocal Pen score. these are very important. Drug-induced liver injury and viral hepatitis are relatively rare, but when they happen, you know about it. Infections are clearly important. Usual signs may be absent. The patient may not always have a fever. Our patient did not have a fever. He was just confused. Acute kidney injury, he also had acute kidney injury, except we did not know what his prior creatinine was. His prior creatinine could have been 0.8, and 1.3 on admission could already have been AKI. Certainly the next day when it became 1.8, it was much worse. Asymptomatic patients can have silent SBP and increase in WBC count. So our patient came with 7,000. It would not have set off any alarms anywhere. But what if his baseline because of hypersplenism was 3.5? This is a doubling of his WBC count, but you would not know it if you had not actually figured it out what was outside. And these things are really critical, because if you miss all of these, this patient can land up in a big pain. In this review that we had written for New England Journal of Medicine in 2021, we divided patients who actually needed infections-related ICU care versus who didn't. And all of these are really very specific to your center. If your center has a high resistance to specific antibiotics, please call your ID colleagues, because patients with cirrhosis are immunosuppressed and they need their guidance. So don't start willy-nilly on things, but if you do start a broad spectrum antibiotic, make sure you draw cultures and then narrow the spectrum when the cultures actually come in. And you want to wait till resolution. Like our patients, if you do not give a patient an adequate antibiotic, an antibiotic that does not cover the underlying bug, is actually no antibiotic at all. Same thing happened. We gave this patient ceftriaxone, even though he had a strangulated inguinal hernia surgery 6 weeks ago, which means this patient had did not have a community-acquired infection. This was a healthcare-associated infection. 9 times higher rate of mortality if you do not treat the patient adequately. Of course, if the patient is in the ICU, you want to also look at all these other things. You want to make sure that you give the map, follow the map, give them hydrocortisone if things do not work, do the abdominal paracentesis very frequently, and ultimately, if things do not work, involve the patient's relatives sooner rather than later. Any patient with cirrhosis who goes to the ICU, you should be starting the palliative care, not end of life, palliative care discussion right then and there, because it happens so fast that families just do not have their head turned. They just don't have the time and wherewithal to actually process all this information. And many of the times the patients are confused themselves. So it's really important for patients with high MELD score that you see in clinic to start talking to them in case things happen, so their wishes are noted somewhere. You don't have to do a full-fledged, power of attorney, etc., although that would be ideal. But you really want to know that in case they're confused, which they often might be because of hepatic encephalopathy and what have you, these patients need to have some kind of guideline for their relatives and for you to follow if things happen and if it is medically appropriate. So these discussions need to be started earlier rather than later. What about giving people albumin? We give a lot of albumin to people and we think it, heals everything. It's only good for SBP and acute kidney injury. Okay, 48 hours to actually prevent acute kidney injury from turning into HRS and making sure it actually responds. And in SBP, clearly it helps because again, it protects the kidneys sooner rather than later. It does not work for non-SBP infections. So if a patient has a pneumonia, has a UTI, anything else, even if their albumin is low, it's not going to work. And in a study called ATTIRE, they randomized almost 800 people across multiple centers in the UK. They gave half the people albumin up to an albumin of 3 grams, and the other ones were standard medical care. Nothing happened, no change in the survival, except patients who received albumin to 3 died more frequently because of respiratory failure. So just giving albumin for the heck of it is not really useful. It may actually be harmful. So we recommend against daily infusion of albumin simply to maintain an albumin level of 3 or higher. Do it for very specific reasons. So for infection, you want to check for infections in hospitalized patients. In suspected infection, early antibiotics. In patients not responding to antibiotic therapy, we recommend suspicion for a resistant organism, which is what happened to our patient. 48 hours it took for us to realize that this patient was not responding. It should have taken a longer time. Or a fungal infection, which obviously none of the antibiotics would cover. But that's why you need to have a direct line with your ID colleagues and your ICU colleagues with these patients. In SBP, albumin and antibiotics to prevent AKI and subsequent organ failures is important, but not in other infections. In prior SBP, antibiotics or secondary prophylaxis are important, but in primary SBP, which is patients who have not had SBP before, this becomes a little more iffy. We also suggest avoiding PPI unless there is a clear indication for the need and for the duration of that patient. Many of your patients who start on PPI were started years ago for some unclear indication, or a clear indication that has outlived its usefulness. So if you do this, that's the best thing you can do for your patient, the last point, because you can do that right now without costing anyone any money. It may actually save the system a lot of money. So here comes the stickiest point. These patients are now in the ICU. Our patient was in the ICU. That was different. This patient was a newly diagnosed patient with cirrhosis, did not have any of the workup for cirrhosis. So it was hard for us to push for transplant for this person. But what if there's a patient like this who's in the ICU with multiple organ failures? You know, we have the MELD score, MELD sodium score, which actually gives you points to see where high up on your list. The philosophy being sickest first. Even if someone has been on the list for several months, if a sicker patient comes in yesterday, that patient will get priority over the person who's been on the list for many, many months, because that person is most likely to die first. But this does not take care of all the other organ failures that the MELD score doesn't necessarily capture. So what are the arguments for? The MELD score does not really capture the disease severity. The patients have acceptable survival for certain grades. If you have 4 organ failures, forget it. They're not going to survive even the surgery, let alone afterwards. But the middle part, there's a huge gray zone. There are futility rules that we need to specify to make sure that we are not wasting a donor organ. Donor organs are very precious. Majority of the transplants that happen in the United States are not living donor. They're actually someone has died, you take their organ, you put it in someone, and then this ethics question comes into play. So there is a score called the TAM score that we can use to find out who's worse and who's not. And there's another score that just came in, but these are all retrospective analyses. These are analyses done agnostic of the ACLF score. So everyone right now has made a decision whether this person is an acceptable transplant candidate or not. ACLF scores never came into that decision making. And now you kind of retrospectively fitting those decisions into ACLF 3, yes, no. So it becomes a little challenging when it's not a prospective study based on ACLF grades. What are the arguments against prioritizing? Many of these databases, etc., do not have the exact things, and there is exhaustion. We cannot take care of, this is a zero-sum game. We can't keep on changing these things for every single person who comes in, because then you're taking this, you're robbing Peter to pay Paul. There's only a specific number of organs that we have available for deceased organs. And if you take it and give it to the ACLF patient who's much likely going to die, compared to someone who has decompensated cirrhosis, who has an infection and now has reached this point, then it becomes a bit challenging for us to justify. There is very little appetite to change listing criteria at this stage, and there's retrospective data and misclassification. So it's really critical right now to remember that if someone comes to you with liver failure, the first order of business, apart from saving that patient's life, is to find out whether they had chronic liver disease before or they did not have chronic liver disease before, because that could make the difference between a life and death for that patient. One of them gets transplant priority, the other one does not at this stage. So we talked a lot about deceased donor. Majority of the Asian countries do not have deceased donor, or do not have, this not as popular. So they have living donor, especially places like India, Korea, China, etc. They have a lot of living donor. So is it really ethical for us to actually put in a part of someone else's liver into this patient with ACLF, and what happens? The living donor related transplant was associated with 73% survival. That is abysmal. That is not very good. That's something that would get your program shut down in the United States. That is not really important, but because that's the only game that they have there at that place. But what we are trying to say is the expansion in the United States of living donor is not going to actually happen or solve the ACLF problem as well, because the outcomes in the best centers where they do only living donor related transplants are not up to snuff also. So therefore, acute on chronic liver failure, why I'm telling you all of this thing, the best cure is prevention. Because once those patients go into the ICU with all these organ failures, they're dependent on us to fix it, but there is no transplant coming to save them unless they fit this very tight and narrow window. So what we suggest is ACLF patients who continue to require mechanical ventilation due to respiratory failure, not because of GI bleeding, not because of encephalopathy, actual respiratory failure, or brain-related conditions despite optimal therapy. Basically, the patients are not getting better. They are not waking up, whatever you wanted to do with them. We suggest against listing them for transplant. And in patients, again, with end-stage liver disease admitted to the hospital, we suggest early goals of care discussion, and if appropriate, referral to palliative care to improve resource utilization. And let's talk a little bit more about the other therapeutic strategies. Of course, general, do no harm, prevent aspiration. Specific therapies like GCSF and stem cell therapy that mobilize cells from the bone marrow to actually make sure there's more hepatocytes that have been transferred. The data are not really convincing. What about liver assist devices, the so-called liver dialysis? Do not work. Living transplant, I just talked about donor transplant. There's greater evidence for deceased rather than living donor. So let's go back to the case. What are the opportunities that we missed that snowballed into ACLF? You had this patient with cirrhosis or chronic liver disease. The patient did not have access to healthcare for a very long time. Of course, that's a much bigger societal question, but that's clearly something with the NASH epidemic. Our profile of patients with cirrhosis has changed. This is not the 45-year-old thin veteran who comes to you with prior hepatitis C because of IV drug use. No, it's a 65-year-old grandma with diabetes and obesity and atherosclerosis. That is the current definition of NASH, of cirrhosis. If you do not feel those, if you do not have a high suspicion of cirrhosis in that patient, you will take forever to diagnose that this is actually acute on chronic liver failure, because most acute on chronic liver failure in the United States is in the basis of cirrhosis. And you actually have to diagnose cirrhosis first before this condition to actually be diagnosed. So really important for your patient who have diabetes, patients who have alcohol use disorder, who are obese, those are the patients, follow their platelet count. If it starts going down, please either take care of them as cirrhosis or refer them to someone who actually will take care of them as well. This patient, we did not adequately diagnose the precipitating factor, which is spontaneous bacterial peritonitis. We did not actually put that patient into the ICU, did not resuscitate him acutely. ICU management was not done appropriately. And of course, this patient was not given a liver transplant, mostly because this was so acute. Liver transplant evaluation takes months or weeks or days in acute liver failure. This is not acute liver failure. It was very clear to us this patient had cirrhosis. So what are the take-home messages? ACLF is a high burden. Prevention strategies, including access to healthcare, are important. And access also means recognition that this patient has cirrhosis. Infections are one of the major causes of ACLF. Bacteriology and mycology of infections is changing radically. A high index of suspicion, flexible, rapid, and appropriate antibiotics. Prevention of acute kidney injury is required to prevent ACLF or infections. Not all high creatinine is hepatorenal syndrome, and not all confusion is hepatic encephalopathy. Use albumin selectively and avoid unnecessary PPI. Palliative care should be involved early, and transplant discussions should be approached with care in patients with ACLF. We still do need better biomarkers. This is the guidelines again, it's published, it's available for free, and these are my acknowledgements, and thank you for your time.